Hey guys, tonight we're talking about something that's probably sitting in your medicine cabinet right now, or at least it used to be, before someone realized it was quietly becoming one of the most abused prescription drugs in America. We're talking about Soma, carisoprodol, the little white muscle relaxer that your doctor called safe, your pharmacist called low risk, and your body eventually called my entire personality. Not exactly the dark, gritty origin story you'd expect from a drug scandal. No back-alley chemists, no illegal labs, no cartel involvement. Just a doctor, a prescription pad, and a lot of back pain. Before you get comfortable, a quick thank you, genuinely a real one, to the viewer who suggested this topic. You know who you are, and you just saved about 30 other people from watching another documentary they didn't ask for. If you enjoy what I do here, please like the video and subscribe, but only if you actually mean it. Leave a comment telling me where you're watching from and what time it is. And if you're already over there on Spotify, we're on there too. Links in the description. Now, dim those lights, flip on a fan for that soft white noise, and get horizontal. Let's pause for a moment though. Have you ever wondered how a drug designed to treat a sore back ends up at the centre of a national addiction crisis? How something your doctor prescribed without a second thought became something people were crushing and snorting in gas station bathrooms? How a medication with the word safe practically baked into its marketing ended up traded on the street under names like DS and Dance, slang your pharmacist definitely didn't mention. Could you have spotted the warning signs if you'd been paying attention? Would the FDA? Would anyone? And congratulations, you've just been handed a prescription. The year is 1996. Your back hurts from sitting wrong at your desk job. Your doctor has 5 minutes and a pen. You have no idea what you're about to start. Before Soma could become a problem, back pain had to become an industry, and in the second half of the 20th century that's exactly what happened. You are living in a country where lower back pain is the single most common reason for a doctor's visit outside of the common cold, where workers' compensation claims for spinal injuries run into the billions, and where the search for relief has quietly built an entire pharmaceutical ecosystem around one question. How do we make the hurting stop without anyone having to change what's causing it? Think about that for a second. The answer was never redesign the office chair. It was never mandate ergonomic assessments, or fund physical therapy, or take a serious look at why a country of 300 million people has collectively destroyed its lumbar spine. The answer, reliably and profitably, was, here's a pill. Back pain became the background noise of American life somewhere around the post-war economic boom when the workforce shifted, not cleanly, not all at once, but decisively. From bodies doing physical labour outdoors to bodies folded into chairs, hunched over desks, commuting in cars and repeating the same motions in the same warehouses for the same number of hours every day. The spine was not consulted about any of this. It adapted as best it could, and then, eventually, it didn't. By the 1980s, the chronic pain patient had become a fixture of the American medical landscape. You know this person. You might be this person. 43 years old, drives a delivery truck, bad disc at L4, L5, has been managing it with ibuprofen and stubbornness since the Clinton administration. Or you're the dental hygienist whose neck gave out at 38 from decades of leaning sideways into other people's mouths. Or you're the teacher who stands on hard floors for 7 hours a day and whose knees have decided to express their grievances loudly and often. The medical system looked at this population, enormous, suffering, motivated to find relief, and largely insured, and responded with the tools it had. Imaging, injections, surgery when things got bad enough, and in the meantime, medication. Muscle relaxers, anti-inflammatories, and increasingly opioids. Not because doctors were malicious, not because patients were weak, but because chronic pain is genuinely hard to treat, because the non-pharmaceutical options were time-consuming and often not covered by insurance, and because a 50-minute appointment has never been long enough to address the biomechanical consequences of a sedentary civilization. Into this environment, the muscle relaxer arrived as a logical solution to a real problem. And for many patients, it was exactly that for a few weeks, for a specific acute injury, taken carefully and discontinued when the inflammation resolved. Used that way, carisoprodol is more or less what the label claimed, a short-term adjunct, a way to break the cycle of spasm so that the underlying tissue can heal. The problem was never the 2-week course for an acute strain. The problem was the 3-year prescription for the chronic ache that never fully went away. The problem was the patient who stopped being able to sleep without it and didn't know why. The problem was a medical system that had built its pain management infrastructure around pharmaceutical intervention and had neither the time nor the incentive to ask what happened when a drug designed for short-term use quietly became a permanent fixture in someone's medicine cabinet. Back pain was never going to go away. It's the price humans pay for walking upright while also inventing the office. What went wrong with Soma wasn't that people were in pain. It was that the system treating the pain was, in certain critical respects, not paying attention to what it was handing out. And the people receiving those prescriptions had absolutely no reason to be suspicious of something a doctor called safe. To understand Soma, you have to go back further than most people realize, back to a mild-mannered Czech pharmacologist named Frank Berger, who wasn't trying to start a revolution. He was trying to preserve penicillin. In 1945, working in a Birmingham laboratory, Berger synthesized a compound called mefenizine while searching for a preservative for the antibiotic. What he noticed instead stopped him cold. When injected into mice, the compound caused a temporary peaceful muscle relaxation. The animals remained conscious. They just stopped tensing up. Berger described the effect as tranquilization, a word that would go on to define an entire pharmaceutical category and eventually a cultural moment. The mice weren't sedated in the heavy, unresponsive way that barbiturates produced. They were calm, relaxed, functional, and when the compound wore off, they went back to normal without apparent distress. From a pharmacological standpoint, this was genuinely interesting. From a commercial standpoint, it was a gold mine that no one had found yet. Mefenizine had a problem, though. It wore off too quickly. Its effects lasted barely long enough to be clinically useful. Berger understood that to make the compound viable, he needed to extend its duration, so he kept working. He modified the molecular structure, tested variations, and eventually, in collaboration with chemist Bernard Ludwig, arrived at a new compound, meprobamate, that lasted longer, produced the same calming effect, and could be taken orally. This was the founding document of the modern tranquilizer. Meprobamate was approved by the FDA in 1955 and marketed under the brand names Miltown and Equinil. What followed was one of the most spectacular pharmaceutical launches in American history. Within a year of its release, it was the most prescribed drug in the country. Celebrities took it. Doctors handed it out for anxiety, tension, insomnia, and what the era's medical literature politely called nervous conditions. It was described in magazine articles as a breakthrough in the management of modern stress. It was, in a very real sense, the first blockbuster psychiatric medication. The original chill pill, decades before that phrase existed. But Miltown's honeymoon did not last. By the early 1960s, reports of dependence and withdrawal, including severe symptoms like seizures in patients who stopped abruptly, began accumulating in the medical literature. The same patients who had been told this was a safe, non-habit-forming alternative to barbiturates were discovering that their bodies had quietly reorganized around the drug's presence. Stopping wasn't as simple as stopping, and this should have been a significant moment of reckoning for the pharmaceutical industry. In some ways it was. Meprobamate was eventually placed on the controlled substances list. Prescribing slowed. But the knowledge that mefenizine's descendant caused dependence, that its metabolic family had a withdrawal profile serious enough to require medical supervision, that knowledge was available. It was in the literature, it was documented, and when carisoprodol arrived 4 years after meprobamate's approval, metabolizing in the human body into that very same compound, the question of whether anyone connected those dots, loudly, clearly, and in time, is one that the history of Soma answers in the most uncomfortable way possible. Quietly, slowly. Too late for a lot of people. Frank Berger died in 2008. By his own account, he was proud of what he'd created. He wasn't wrong to be. The science was real. The problem, as always, was what happened after the science left the laboratory. By the late 1950s, meprobamate had become one of the best-selling pharmaceuticals in American history, and that success had not gone unnoticed. A New Jersey company called Wallace Laboratories began working on a structural cousin of meprobamate, one that they hoped could deliver muscle relaxation without the sedative baggage that was starting to make regulators nervous. The result was carisoprodol, approved by the FDA in 1959 and marketed under the brand name Soma, a name borrowed, intentionally or not, from Aldous Huxley's Brave New World, where Soma was the government-issued happiness pill that kept the population quiet and compliant. Whether the naming was literary allusion or coincidence, it was a remarkable choice. In Huxley's novel, Soma was the perfect drug. No hangover, no consequences, no unpleasant come-down, just a reliable, state-approved sense of well-being on demand. The citizens of the world state took it without question because they had been told it was harmless, and questioning harmlessness requires a degree of suspicion that the novel society had been engineered to eliminate. You could spend a long time thinking about what it means that a pharmaceutical company chose that particular name, or you could just note it and move on. Either way, it's there. The pitch for carisoprodol was straightforward. Here was a muscle relaxant that worked on the central nervous system to interrupt the pain spasm cycle, the feedback loop where an injury causes muscle tension, which causes more pain, which causes more tension, without the pronounced sedation that was making meprobamate controversial. The early clinical data supported this framing well enough. In controlled trials, patients reported relief. Prescribers found it useful. The side effect profile looked manageable. And crucially, in the short-term studies that formed the basis for approval, dependence didn't look like a significant concern. This is where the timeline becomes important. Carisoprodol was approved for short-term use. The label said so explicitly. 2 to 3 weeks was the intended duration. The clinical rationale was sound. Acute muscle spasm, the kind you get from a specific injury, doesn't last longer than that in most cases. You prescribe the drug, the muscle relaxes, the injury heals, you stop the drug. Clean, logical, finite. The problem is that back pain is often not acute. It's often not clean or logical or finite. And the patients who walked into doctors' offices in 1960, 1970, 1980, 2000 were not presenting with tidy 2-week injuries. They were presenting with chronic conditions that would outlast any short-term prescription by years. The FDA approval was for acute use. The prescribing reality was chronic use. And nobody, not the manufacturer, not the regulator, not the prescribers writing the scripts, made enough noise about the gap between those two things. Refills were written. Prescriptions were renewed month after month. Patients who reported that the drug really helped were kept on it, because the alternative, a patient in pain, asking for something that worked, being told no, required a conversation that a 15-minute appointment struggled to accommodate. The name Soma stuck. Not just as a brand name, but as a cultural shorthand. Patients asked for it by name, requested it specifically at follow-up appointments, mentioned it to friends who mentioned it to their own doctors. Brand loyalty in pharmaceuticals is a well-documented phenomenon, and Soma developed it faster than almost any muscle relaxer before or since. By the time the patent expired and generic carisoprodol flooded the market, the name was already embedded. People still called it Soma. They still do, which is either a triumph of marketing or a small, persistent irony, depending on how you feel about Aldous Huxley. Here's where it gets interesting, and a little inconvenient for everyone who spent decades insisting Soma was just a muscle relaxer with no abuse potential. Because Soma doesn't actually work on your muscles. Not directly. It works on your brain. Once swallowed, carisoprodol is metabolized by your liver into a compound called meprobamate, the same anxiolytic sedative that had already been identified as habit-forming decades earlier. The muscle relaxation you feel is a secondary effect of your central nervous system being generally, comprehensively calmed down. To understand why this matters, it helps to think about what a muscle relaxer actually is. There are two broad categories. The first works directly at the neuromuscular junction, the point where the nerve signal tells the muscle to contract, and blocks that signal at the source. These are used in surgical anesthesia. You know them from hospital dramas, the drugs that paralyze patients before intubation. The second category, which includes carisoprodol, doesn't touch the neuromuscular junction at all. It works upstream, in the central nervous system itself, dampening the signals before they even reach the muscle. Your muscle relaxes not because anything changed at the muscle, but because your brain got quieter. Specifically, carisoprodol modulates GABA receptors, the same receptor family targeted by benzodiazepines and barbiturates. GABA is your brain's primary inhibitory neurotransmitter, the molecular equivalent of a volume knob being turned down. When you enhance GABA activity, everything slows, anxiety decreases, muscles loosen, sleep becomes easier, and in higher doses, consciousness itself becomes negotiable. This is why people who take Soma recreationally describe the experience in terms that sound much more like a benzodiazepine than an aspirin. The warmth, the looseness, the sense that whatever was tightly wound has simply let go. That's GABA. That's meprobamate. That's your brain being told chemically to stand down. The meprobamate metabolite reaches peak concentration in your bloodstream approximately 2 to 3 hours after you take carisoprodol. Its half-life, the time it takes your body to eliminate half the dose, is between 6 and 17 hours, which means it's still pharmacologically active the next morning. Depending on your liver enzymes, your body composition, and whether you've taken anything else, the compound can accumulate over repeated doses to levels significantly higher than any single therapeutic dose would suggest. This is one reason tolerance develops. The brain, receiving a sustained signal to calm down, begins to compensate by becoming structurally less sensitive to that signal. And here is the part that should have generated more alarm than it did, earlier than it did. Physical dependence follows naturally from that adaptation. When you remove the drug, the brain, now calibrated to function with GABA enhancement, finds itself operating without the support it has reorganized around. The result is a rebound effect in the opposite direction. Anxiety, agitation, muscle cramping, insomnia, tremors. In severe cases, particularly after high dose or long duration use, withdrawal from carisoprodol can cause seizures, actual seizures. From a muscle relaxer your doctor prescribed for your bad back without suggesting you'd need medical supervision to stop taking it. None of this was secret science locked in obscure journals. The meprobamate metabolite was known from the drug's earliest pharmacological characterization. The GABA mechanism was understood. The dependence liability of the meprobamate family had been documented since the early 1960s. The information existed, it just didn't make it, with sufficient clarity and urgency, into the clinical culture surrounding a drug that everyone had already decided was safe. If there's one phrase that haunts the history of Soma, it's this one: low abuse potential. It appeared in early clinical literature, it was echoed by prescribers, it was implied in pharmaceutical marketing materials, and it embedded itself into medical culture so thoroughly that by the time anyone seriously questioned it, millions of prescriptions had already been written. The argument was simple and, on its surface, not completely unreasonable. Because carisoprodol required a prescription, because it was being used in clinical settings, and because no one was injecting it or smoking it, surely the risk was manageable. This is a category of pharmaceutical reasoning that the opioid crisis should have permanently retired but hasn't. The idea that the manner of a drug's use determines its abuse potential. The logic runs like this: illicit drugs are dangerous partly because they're used illicitly, in uncontrolled doses, by people without medical supervision, through delivery methods that maximize speed and intensity of effect. Prescription drugs taken as directed don't fit that profile. Therefore, prescription drugs are inherently safer. Therefore, a prescription muscle relaxer with no injection route and a doctor's name on the label is not the kind of thing we need to worry about. What this logic misses is the pharmacology. It doesn't matter whether you take meprobamate as a branded anxiolytic from a psychiatrist in 1958 or as a metabolite of carisoprodol from a pain clinic prescription in 2004. Your GABA receptors don't read the label. They respond to the compound. And the compound, taken repeatedly, in a brain that is biologically capable of adaptation, produces dependence regardless of whether the person taking it considers themselves a drug user. The pathway from legitimate patient to physically dependent person is not a moral failing. It's a receptor response. It happens whether you want it to or not. The low abuse potential narrative also depended on a narrow definition of abuse, one that emphasized recreational intent, that prioritized the dramatic image of misuse over the quieter reality of dependence in therapeutic users. By that definition, the middle-aged woman taking Soma every night for 3 years, because she can't sleep without it, isn't an abuser. She's a patient. The distinction is true in one sense and meaningless in another, because her body's experience of withdrawal, if she tries to stop, is identical either way. Pharmaceutical marketing in this era was not obligated to foreground risks that hadn't yet generated sufficient regulatory pressure. And because the controlled substance scheduling that would have required more prominent abuse and dependence warnings didn't arrive until 2012, the label on a Soma prescription for most of its history read more like an advertisement than a warning. Physicians prescribing it in good faith were working from a knowledge base shaped substantially by the same framing. Ask a doctor in 1995 about Soma's addiction potential, and you would, in many cases, receive an honest, well-intentioned answer that was simply wrong. Not because the doctor was careless, but because the information environment had been shaped by decades of messaging that pointed in one direction. By the time studies began seriously documenting what was happening in chronic users, the drug had been on the market for 40 years. Its reputation was established. The people who needed to change their prescribing behavior had to fight against decades of accumulated clinical habit. That's not a quick fix. That's not a single regulatory action. That's a cultural change in medicine, and those move at a pace that doesn't align neatly with the speed at which people become dependent on something their doctor told them was safe. The people being prescribed Soma in its peak years weren't the faces you might picture when you think about drug abuse. They were construction workers with blown-out lumbar discs. They were middle-aged women with fibromyalgia who hadn't slept properly in 3 years. They were truck drivers, warehouse workers, and office employees with repetitive strain injuries. They were your neighbour, your aunt, and frankly, depending on when you're listening to this, possibly you. The profile matters because the Soma story, like the opioid story before it and alongside it, is frequently told as a story about a specific kind of person making specific kinds of bad choices. That framing is comfortable because it implies a clear boundary between the people who ended up with a problem and the people who didn't. It suggests that the difference is character, or caution, or some quality of personal responsibility that protected the careful people and failed to protect the careless ones. And that framing is, with a few exceptions, almost entirely wrong. The construction worker who blew out his disc at 41 wasn't making a bad choice when he filled his Soma prescription. He was in genuine pain. He had a job he needed to return to, and his doctor, a real doctor in a real clinic, had given him something that worked. The fibromyalgia patient wasn't being reckless when she refilled her prescription for the 4th month in a row. She had tried the alternatives. Physical therapy helped a little. The anti-inflammatories bothered her stomach. Soma let her sleep. When something lets you sleep after 3 years of not sleeping, you do not interrogate its mechanism of action. You fill the prescription. What the typical Soma patient had in common was not a predisposition to addiction in the dramatic sense, not a family history of heroin use or a background in recreational drug culture. What they had in common was chronic pain in a system that was better equipped to prescribe than to heal, and a drug that provided real relief in the short term and reliable physical dependence in the medium term. The transition from patient to dependent person happened gradually and invisibly, often without the prescribing doctor ever flagging that anything had changed. Women were prescribed Soma at higher rates than men, partly because fibromyalgia and certain chronic musculoskeletal conditions are more prevalent in women, and partly because the cultural history of prescribing sedating medications to women with pain and anxiety is long and not particularly flattering to the medical profession. Older patients were prescribed it at high rates despite the explicit recommendations of geriatric pharmacology guidelines, which flagged Soma as inappropriate for elderly patients due to its CNS depression effects and fall risk. Workers in physically demanding industries were prescribed it at high rates, because those industries produce the kinds of injuries that Soma was designed to treat. The typical Soma patient was, in other words, a person in pain who was given a medication by a professional they trusted and had no particular reason to distrust. The fact that a meaningful percentage of those patients ended up physically dependent is not a story about individual weakness. It is a story about a drug that was distributed at enormous scale with insufficient warning to a population that was vulnerable in entirely predictable ways by a system that was, for too long, not paying close enough attention to what it was doing. Somewhere along the way, word got out. Not in a formal study or a medical journal, but in the way that drug knowledge always travels fastest. From person to person, in parking lots and break rooms and pain clinics, with suspiciously short appointment times. People discovered that Soma taken alongside an opioid, most commonly hydrocodone, produced something that wasn't quite either drug on its own. The combination created a wave of sedation that users described as warm, heavy, and profoundly relaxing. Throw in a benzodiazepine, and you had what the street was already calling the Holy Trinity. The pharmacology of why this combination is dangerous is worth understanding, because it's not simply the case that 3 sedating drugs are 3 times as risky as 1. The relationship between CNS depressants is not additive in a linear sense, it's synergistic, meaning the combined effect exceeds what you would predict by simply adding up the individual effects. Opioids suppress respiratory drive by acting on receptors in the brainstem. Benzodiazepines and the meprobamate metabolite of carisoprodol enhance GABA activity, which independently reduces respiratory rate and depth. When you stack these mechanisms, each one lowers the threshold at which the other becomes dangerous. In practical terms, a dose of hydrocodone that a long-term opioid user tolerates without difficulty can become a lethal dose when carisoprodol is in the system. Not because the opioid dose changed, because the system it's acting on has been simultaneously suppressed by the muscle relaxer's metabolite. The breathing slows, the person feels warm and heavy and comfortable, and in some percentage of cases, in some of the more vulnerable positions, lying on their back, alone, late at night. The breathing doesn't recover. The medical examiner lists the opioid. The Soma is in a footnote. The Holy Trinity had a geography and a demography. It was popular in regions with high opioid prescribing rates, which meant it tracked closely with the pain clinic culture of the American Southeast and parts of the rural Midwest. It was disproportionately documented in populations already cycling through the same prescribers for multiple controlled substances, and it appeared repeatedly in the toxicology reports of overdose deaths, in a pattern consistent enough that researchers and law enforcement were noting the combination in the mid-2000s, well before carisoprodol was federally scheduled. What made the Trinity particularly difficult to address was that each component could be prescribed by a different provider with no visibility into what the others were prescribing. A pain clinic prescribed the Soma. A different physician managed the hydrocodone. A psychiatrist or primary care doctor handled the Xanax. None of them necessarily knew what the others were doing. Before prescription monitoring programs were mandatory and interoperable, the patient was the only node in the system with complete information, and patients were not always in a position to understand what that information meant. The name Holy Trinity deserves a moment's uncomfortable attention. It's dark humour of the specific variety that emerges from communities living inside a crisis. The kind of naming that simultaneously acknowledges danger and domesticates it. that makes the unbearable slightly more bearable by giving it a wry, irreverent label. The people who coined the term were not unaware that it was a killing combination. The name is, in its own way, a form of documentation, evidence that communities understood the risk long before the regulatory apparatus caught up to it. The 1990s and early 2000s saw the rise of a peculiar American institution, the pain clinic. In theory, these were legitimate medical facilities providing specialized care for patients with chronic pain conditions. In practice, some of them were little more than waiting rooms with clipboards, where a brief conversation about back pain reliably ended with a prescription for a month's supply of Soma, an opioid, and something for anxiety. No imaging required, no physical therapy referral, no follow-up scheduled. Florida became the national symbol of the pill mill phenomenon, to the point where the term Florida pill mill became a shorthand recognizable in congressional testimony and DEA reports. At the peak of the crisis, Florida had more pain clinics per capita than any other state in the country, and some of the highest prescribing rates for both opioids and carisoprodol in the nation. Patients drove to Florida from states as far away as Ohio and Tennessee, long distances in cars loaded with people, everyone with a complaint and everyone expecting to go home with a prescription. The round trip became its own economy. Gas money, hotel rooms, the price of the appointment, the cost of the pills, and then the drive back, which was worth it because the street value of what you'd just been handed covered the expenses and left something over. The architecture of the pill mill was straightforward. A physician, sometimes genuinely licensed, occasionally with a disciplinary history that a 5-minute background check would have revealed, would see patients for brief appointments. The appointments followed a recognizable pattern. Chief complaint of pain, brief physical or no physical examination, prescription written. The combination was often predetermined: oxycodone, carisoprodol, and alprazolam, or another benzodiazepine. This was the package. If you came in with the right complaint, you left with the right prescription. Cash preferred. Some clinics dispense directly from the office, which is both a convenience and a regulatory red flag significant enough to have its own dedicated section in DEA enforcement guidelines. What made the pill mill difficult to shut down was not that it was invisible, it was visible. The cars in the parking lot with out-of-state plates, the patient volumes no legitimate pain practice could justify, the prescribing patterns that showed up in pharmacy records as statistical outliers. The problem was jurisdictional and institutional. Regulatory boards were underfunded. Law enforcement needed evidence of criminal intent, which required time and resources. Prescribers knew exactly where the legal lines were and how to operate just inside them. And some of the prescribing, while extreme and irresponsible by any reasonable clinical standard, was technically legal. The patients who drove to these clinics were not all recreational users. A significant portion had real chronic pain. They had been failed by a standard medical system that couldn't adequately treat them, and had found, through word of mouth, a place that would at least reliably provide something that worked. The pill mill served a real demand with a deeply irresponsible supply. That doesn't make what happened morally neutral, but it does complicate the story of who the villains were and whether the people cycling through those waiting rooms were primarily perpetrators or primarily victims of a system that had created the conditions for exactly this outcome. Drugs develop street value when 3 things align. They produce a desirable effect, they're accessible enough to move in volume, and they're underestimated enough by law enforcement to fly under the radar. By the early 2000s, Soma had quietly cleared all 3 bars. On the street, pills went by names like Diaz Dance and simply Somas, sold loose in sandwich bags or traded in parking lots outside pharmacies. The price was modest, rarely more than a few dollars per pill, but the volume more than compensated. The accessibility piece was crucial. Carisoprodol, unscheduled at the federal level until 2012, was available through the prescription pipeline in quantities that a truly controlled substance would not have been. A patient seeing multiple providers, filling prescriptions at multiple pharmacies, and diverting a portion of their monthly supply could generate a meaningful quantity with relatively low legal risk. The drug was not being smuggled across borders or cooked in clandestine labs. It was coming directly from the pharmacy, authorized by a physician, and hitting the street with the DEA imprint still on the tablet. The law enforcement angle is worth dwelling on. For much of carisoprodol's history, street-level possession was not a federal crime. Arresting someone with Soma in a state where it wasn't yet scheduled was, at most, a minor local charge, if it was a charge at all. Officers working drug enforcement in high-use areas describe the frustration of finding Soma alongside clearly controlled substances during stops and searches, and being unable to do anything specific about the muscle relaxer. The legal landscape created a kind of protective shadow. Soma could travel with opioids, could be combined with opioids, could substantially enhance the danger of opioids, and still be treated by the legal system as essentially unremarkable. On the user side, the appeal was not simply recreational in the way that word usually implies. For people already dependent on opioids, Soma functioned as a potentiator, something that extended and deepened the effect of their primary drug. For people in genuine pain who couldn't access or afford adequate treatment, it was a relief option that was cheaper and more available than a legitimate medical appointment. For people who had been prescribed it legitimately and were now dependent but couldn't get refills, the street was the continuation of a treatment they couldn't access through official channels. This creates a picture more complicated than the standard narrative of drug diversion, where a clearly recreational market is being supplied by a corrupt or careless medical system. The people buying Soma on the street were not a monolithic population. Some were recreational users seeking the Holy Trinity experience. Some were dependent patients trying to manage withdrawal. Some were chronic pain sufferers navigating a broken healthcare system from the outside. The street market served all of them indiscriminately, which is the defining characteristic of any market operating outside regulatory oversight. It doesn't distinguish between the people it's helping and the people it's harming, because making that distinction has never been part of its function. What the black market for Soma demonstrated most clearly was that the demand the drug addressed was real. Real pain, real dependence, real inadequacy of legitimate alternatives, and that when the legal system fails to adequately regulate a substance with significant abuse potential, the market fills the gap in ways that are predictable, dangerous, and entirely avoidable in hindsight. If there was a geography to the Soma crisis, it ran along the Appalachian spine of the American Southeast, through parts of Kentucky, West Virginia, Tennessee, and Alabama. The same communities that were simultaneously being devastated by the opioid epidemic. This was not a coincidence. The same economic conditions that made opioid abuse rates skyrocket in these regions, chronic unemployment, physical labour, inadequate healthcare, and a long history of being medically underserved, also made Soma a fixture. The physical labour piece is foundational. Appalachian economies were built on extractive industries, coal mining, timber, manufacturing, that produced outsized rates of musculoskeletal injury. A coal miner's body, after 20 years underground, carries a specific catalogue of damage: compressed discs, repetitive strain injuries, joint deterioration, chronic pain that is both real and largely untreatable in a region where specialist care requires a 2-hour drive and a copay that competes with groceries. The back pain that Soma was designed to treat was not metaphorical in these communities. It was structural, occupational, and absolutely genuine. Into this landscape of real physical pain arrived a healthcare system that was under-resourced, underfunded, and, in some corners, operating with a financial structure that made high-volume prescribing more viable than comprehensive care. Rural pain clinics in this region saw enormous patient loads. Prescribers working in these settings were dealing with populations that had limited alternatives. If medication management was what the system offered, medication management was what patients received. The notion that a physician in a rural Kentucky clinic could have substantially redirected their chronic pain patients toward physical therapy, occupational medicine, and surgical evaluation is not false. It's just disconnected from the reality of what those resources looked like and where they were accessible. The economic dimension compounded everything. When the industries that had employed these communities began contracting, when mines closed, when manufacturing moved, when the economic base that had justified the physical damage eroded, the communities were left with the injuries without the wages, the pain without the insurance, the dependence without the legitimate prescription pipeline. Disability claims increased. Workers' compensation caseloads swelled. And the informal economy that had grown up around prescription diversion became, for some households, a meaningful part of their financial survival. The overdose data from this corridor was alarming by the mid-2000s and only became more so through the following decade. Carisoprodol appeared in toxicology reports alongside opioids and benzodiazepines with a frequency that was impossible to attribute to coincidence. West Virginia, which had the highest opioid overdose death rate in the country for most of this period, also had some of the highest carisoprodol prescribing rates. The correlation was not subtle. What the Southeast Corridor demonstrated was that the Soma crisis was not randomly distributed. It concentrated in places where bodies were damaged, healthcare was insufficient, economics were desperate, and regulatory oversight was stretched thin. It followed the same fault lines as every other pharmaceutical crisis of the era, because pharmaceutical crises do not distribute themselves randomly. They find the places where the ground is already broken and go deeper. Appalachia did not create the Soma problem. It revealed the conditions under which a problem becomes a catastrophe. There's a particular kind of helplessness that pharmacists working in high-prescribing regions described during this period. You stand behind a counter and you watch the patterns. You see the same names cycling through every 30 days, always requesting early refills, always paying cash, always for the same combination of medications. You notice which prescriber's name appears on every other script. You know what you're looking at. But the prescription is valid, the doctor is licensed, and your job is to fill it. The pharmacist's position in the prescription drug crisis is one of the most structurally uncomfortable in American healthcare. Pharmacists are trained clinicians. The average pharmacy degree involves more pharmacology coursework than a medical degree, and they frequently possess the knowledge to identify problematic prescribing patterns faster than any other point in the system. They see the combinations, they see the quantities, they see the patient who is picking up controlled substances from 4 different prescribers and hoping no one notices. And in the absence of interoperable prescription monitoring databases, they were often the only person in the system with that view. But the legal and professional framework governing pharmacy practice did not, for most of this period, give pharmacists clear authority to refuse a prescription on the basis of pattern recognition alone. A valid prescription from a licensed prescriber created a professional obligation to fill, and departing from that obligation required documentation of a specific clinical concern strong enough to justify the refusal and survive a complaint to the licensing board. Noting that a patient seemed to be picking up a lot of Soma was not, by itself, a refusal-worthy finding. Proving that a prescriber was operating a pill mill required evidence, and gathering evidence was not a pharmacist's job. It was law enforcement's. This created a situation where the people with the clearest view of the problem had the least structural authority to act on it. Pharmacists who did refuse to fill, who pulled a patient aside, who called a prescriber to question a combination, who flagged a pattern to their state board, did so at professional and sometimes legal risk. A prescriber who felt that a pharmacist had improperly interfered with their clinical judgment had recourse. The pharmacist who had simply been trying to protect a patient had, in many cases, very little. The introduction of mandatory prescription monitoring program queries into pharmacy practice changed this calculus significantly and in the right direction. When a pharmacist can see, before dispensing, that a patient has filled carisoprodol at 4 different pharmacies in the past 30 days, that information transforms a pattern-based suspicion into a documentable clinical finding. It gives the pharmacist something to point to. It gives the refusal a basis, and it shifts the professional burden from the pharmacist's judgment to the data itself. The pharmacists who watched the Soma crisis from behind their counters and knew what they were seeing deserve acknowledgement in this story. They were not passive participants. Many of them were the only people actively trying to slow the pipeline, with inadequate tools, in an environment that was not designed to support them. The system failed them as thoroughly as it failed the patients they were trying to protect. And the lesson that clinical gatekeeping requires clinical authority, and that authority requires infrastructure, is one the American pharmacy system has been slowly, imperfectly learning ever since. Here's something that took an embarrassingly long time to become mainstream medical knowledge. When you take carisoprodol, your body converts a significant percentage of it into meprobamate within about 30 minutes. Meprobamate was a Schedule I-4 controlled substance, already recognized as having abuse potential and physical dependence liability. Carisoprodol itself, however, was not scheduled at the federal level until 2012. The active metabolite had been controlled for decades. The parent drug was still available essentially unrestricted. The metabolic conversion is not a minor footnote. Depending on individual variation in the liver enzyme CYP2C19, the primary enzyme responsible for the conversion, somewhere between 30 and 60% of a carisoprodol dose becomes meprobamate in the body. People who are what pharmacologists call extensive metabolizers, and a significant percentage of the population falls into this category, convert more of the drug more rapidly. Their plasma meprobamate levels after a standard carisoprodol dose are meaningfully higher than those of poor metabolizers. Their experience of the drug and their dependence liability is correspondingly different. This genetic variability created a situation where the same prescription produced substantially different effects in different patients. But those differences were invisible to the prescriber, unlabeled on the bottle, and not discussed during the appointment. The doctor who prescribed Soma to 3 patients with back pain gave each of them the same dose. One metabolized it slowly and experienced modest muscle relaxation. One metabolized it moderately and experienced effective pain relief with mild sedation. One metabolized it rapidly, felt something warm and comprehensive and profoundly calming, and came back in 30 days wanting more. All 3 left with the same prescription. The genetics were doing the work that the pharmacology discussion hadn't. The scheduling discrepancy, meprobamate controlled, carisoprodol not, was not a secret. It was documented in the pharmacological literature and noted in petitions to the DEA as early as the late 1990s. The argument for scheduling carisoprodol made explicit reference to the metabolite. You have already determined that this compound is a controlled substance. You're allowing it to be freely dispensed via a drug that becomes that compound in the human body. The logical consistency of that position is not obvious. Several states responded by adding carisoprodol to their own controlled substance schedules independently. The federal response took considerably longer. There's a specific kind of regulatory inertia that operates on the principle that absent a formal finding, the status quo persists. Carisoprodol had been approved. The label existed. The scheduling review was a separate, time-consuming process with its own evidentiary standards. And while that process was running, slowly, across years and then decades, the drug was being prescribed to millions of patients whose physicians had no particular reason to tell them that their muscle relaxer would be metabolized into a controlled substance in their liver approximately half an hour after they swallowed it. That information gap is not simply a curiosity of pharmaceutical history. It is the structural explanation for why so many patients ended up dependent on a drug they had every reason to believe was benign. The chemistry was known. The connection to meprobamate was documented. The inconvenience was not scientific. It was institutional, regulatory, and ultimately a question of who bore the cost of acting on information that was already in the room. Throughout the 1990s and into the 2000s, a growing body of research began doing what the original clinical trials hadn't adequately done, looking at what happened to Soma patients over time. The findings were not reassuring. Studies documented physical dependence developing in patients taking therapeutic doses for as little as a few weeks. Withdrawal symptoms, anxiety, insomnia, tremors, and in severe cases, seizures and psychosis, were reported in patients who stopped suddenly after short-term use. The original approval studies for carisoprodol, conducted in the 1950s and early 1960s, were designed to the standards of their era, which is to say they were short, small, and optimized to demonstrate efficacy rather than characterize long-term risk. A typical study enrolled patients with acute musculoskeletal pain, gave them carisoprodol or placebo for 1 to 3 weeks, and measured pain relief outcomes. These studies did what they were designed to do. They showed the drug worked for short-term pain. They were not designed to show what happened at month 3 or month 12, or in a patient population that used the drug continuously for several years. By the time researchers began asking those longer-term questions, the drug had been on the market for decades. The methodological challenge was compounded by the fact that carisoprodol was rarely prescribed in isolation. Most patients in real-world clinical settings were also taking opioids, benzodiazepines, or other CNS active medications. Separating the carisoprodol signal from the noise of a polypharmacy environment required study designs more sophisticated and more expensive than anyone had been motivated to fund, while the drug was comfortably classified as a benign muscle relaxer. When the well-designed studies did arrive, the findings were consistent enough to be uncomfortable. Case reports of carisoprodol withdrawal in patients with no prior substance use history accumulated in the clinical literature through the 1990s. Drug abuse surveys began documenting carisoprodol as a misused substance. Emergency department data showed carisoprodol appearing with increasing frequency in presentations for overdose and adverse drug reactions. The Drug Abuse Warning Network, which tracks emergency department mentions of specific substances, documented a significant rise in carisoprodol-related visits through the late 90s and into the 2000s. Each of these data streams told the same story at a slightly different angle. The drug that was classified as having low abuse potential was, empirically, being abused in meaningful quantities, was producing dependence in therapeutic users, and was contributing to overdose deaths in combination with other CNS depressants. The question of what to do with this accumulating evidence ran into the standard institutional headwinds. Scheduling review is a formal process. The data needed to meet a specific evidentiary threshold, and in the meantime the drug remained on pharmacy shelves, unrestricted in most of the country. The gap between what the research was showing and what the regulatory framework reflected is not unique to carisoprodol. It is the characteristic pattern of pharmaceutical risk recognition in the American system. A lag between the emergence of evidence, the formal acknowledgement of that evidence, and the policy response to it. In that lag, which for carisoprodol measured in decades rather than years, the patients lived, took their prescriptions, and learned, slowly and often painfully, what the research was in the process of documenting. Soma withdrawal doesn't announce itself politely. It arrives approximately 12 to 24 hours after the last dose with a familiar misery, insomnia, muscle cramping, nausea, that most patients initially mistake for their original pain returning. This is the first and cruelest trick of physical dependence. The symptoms of withdrawal are often indistinguishable from the symptoms the drug was prescribed to treat, which makes stopping feel medically irresponsible, even when continuing is the actual risk. Think about the position this creates. You were prescribed Soma for back pain. You took it for 6 months. Your back improved more or less, but you notice that on the mornings you skip your dose, the pain seems worse than it did before you started the medication. Your muscles ache. You can't sleep. You feel anxious in a way that doesn't track with anything happening in your life. The logical conclusion, The conclusion that your body is actively delivering to you through every receptor it has is that your back needs the medication, that the pain you're feeling is evidence that you still require treatment, and so you fill the prescription again, and the symptoms resolve, and the cycle continues. This is not weakness. This is the pharmacology working exactly as physical dependence is designed to work. The brain, having adapted to the presence of carisoprodol's meprobamate metabolite, interprets its absence as a deficit state. It generates signals, anxiety, pain amplification, sleep disruption, that function as demands for the missing compound. The patient experiences those signals as symptoms of their underlying condition. The prescriber, if consulted, often interprets them the same way. The prescription is renewed, the dependence deepens. Severe carisoprodol withdrawal in patients who have been taking high doses for extended periods looks clinically similar to benzodiazepine or barbiturate withdrawal, which are among the more medically serious withdrawal syndromes in clinical practice. Seizures can occur within the first 48 hours of abrupt discontinuation. Delirium has been documented. In the medical literature, there are case reports of fatal carisoprodol withdrawal, which places it in a category that most patients, and many prescribers, did not understand the drug to occupy. The recommended clinical approach to carisoprodol discontinuation for dependent patients is gradual tapering rather than abrupt cessation, reducing the dose slowly over weeks to give the brain time to recalibrate without triggering severe rebound. This is sound pharmacology. It is also information that was not routinely communicated to patients at the point of prescription because the drug was classified in a way that did not obligate anyone to have that conversation. Patients who tried to stop on their own without medical guidance frequently failed, not because they lacked motivation, but because the withdrawal symptoms were medically significant and clinically undertreated. The withdrawal problem is perhaps the most direct illustration of what it costs when a drug's dependence liability is misclassified. It's not abstract. It's a person lying awake at 3 a.m, muscles cramping, convinced that they cannot function without a pill, with no information about why they feel this way and no clinical support for getting through it. That person is not dramatic. They are not being difficult. They are experiencing the predictable pharmacological consequence of a drug that was handed to them without adequate warning, and they deserve a better answer than you should have been more careful. For years, Soma's contribution to overdose deaths was undercounted, misattributed, and obscured by a simple methodological problem. Most people who died with carisoprodol in their system also had opioids, benzodiazepines, or alcohol in their system. Medical examiners typically listed the opioid as the primary cause. Soma became a footnote, a contributory factor, a supporting actor in a toxicology report, rarely the headline. This framing had consequences. When a drug appears in toxicology reports primarily as a secondary or contributory finding rather than a primary cause of death, it generates a specific kind of statistical invisibility. The overdose databases that inform regulatory and public health decision-making are organised largely around primary causes. The opioid that stopped someone's breathing is the opioid that gets counted in the opioid overdose rate. The carisoprodol that lowered the threshold at which the opioid became lethal is noted, if it's noted at all, in a supporting field that rarely drives headline figures. The drug that kills quietly in combination gets studied less urgently than the drug that kills loudly on its own. This isn't a flaw in the data collection system so much as a reflection of how overdose deaths are medically understood. Determining the primary cause of death in a polydrug overdose requires a clinical judgment about which compound was most directly responsible for the respiratory failure. When opioids are present, they are the most established and most recognized cause of respiratory depression. They take the attribution. The other drugs in the system, the ones that made the fatal dose possible at a lower opioid concentration than it would otherwise have required, recede into the background. The medical examiner's dilemma here is genuine. In many polydrug overdose cases, it is not possible to say with certainty whether the person would have survived without the carisoprodol. You can model the pharmacokinetics. You can consult the literature on synergistic respiratory depression. You can make an educated and well-supported clinical judgment that the combination was more dangerous than the opioid alone. But the standard of proof required to attribute causation in a death investigation is appropriately high, and in the absence of a formal finding that carisoprodol was the proximate cause, it was the contributory cause, and contributory causes moved more slowly through the data toward regulatory action. What couldn't be ignored eventually was the sheer consistency of the pattern. Carisoprodol didn't appear in overdose toxicology reports occasionally or randomly. It appeared with a frequency and in a combination profile: opioid plus muscle relaxer plus benzodiazepine dose. That was statistically improbable unless those combinations were being used deliberately and repeatedly. Researchers who analysed medical examiner data across multiple states and multiple years found carisoprodol in a significant percentage of opioid overdose deaths. The number varied by region and by time period, but the signal was there, consistently across the data. The deaths that couldn't be ignored were eventually what moved the regulatory needle. Not just the research, not just the abuse surveys, not just the DEA petitions, but the accumulated weight of toxicology reports making the same argument across years. This drug is in the system when people die. It is not a coincidence. It is a contribution. And the classification structure that treated it as a non-controlled substance, while its active metabolite was already controlled, was a classification structure that was measurably costing lives. The process by which carisoprodol was finally placed on the federal Schedule F4, Controlled Substances List in 2012 reads, in hindsight, as a case study in institutional slowness. The DEA had received formal petitions for scheduling as early as the late 1990s. State-level agencies in places like Texas, Florida, and Georgia had already moved to schedule the drug within their own jurisdictions, often more than a decade before federal action. The evidence, overdose data, abuse surveys, hospital admission records, accumulated year after year. Federal scheduling under the Controlled Substances Act follows a formal two-agency process involving both the DEA and the FDA. A petition is filed, a medical and scientific evaluation is conducted, the FDA provides a recommendation, and the DEA makes a scheduling determination. The process is designed to be rigorous, and in the abstract, rigor is the right approach. You don't want controlled substance classifications made on insufficient evidence. But the same procedural requirements that prevent hasty scheduling also create the conditions for extended inaction in cases where the evidence is clear and the harm is ongoing. The first formal petition to schedule carisoprodol was submitted to the DEA in 1999. The agency conducted a preliminary review and declined to initiate scheduling proceedings at that time, citing insufficient evidence of a significant current pattern of abuse. The abuse data that existed at that point was real, but not yet at the volume that the standard required. The petition was essentially deferred pending further documentation. The documentation arrived steadily over the following decade in the form of rising emergency department mentions, increasing state-level scheduling actions, and a growing body of published research on dependence and overdose contribution. A second, more substantial petition followed. The FDA's evaluation, when it was finally completed, concluded that carisoprodol met the criteria for Schedule 4 placement, the same schedule as benzodiazepines, the same schedule as the meprobamate metabolite that had been there for years. The DEA agreed. The final rule went into effect in January of 2012. From first petition to federal scheduling, approximately 13 years. The question of whether those 13 years cost lives is not really a question, it is a calculation. During those 13 years, carisoprodol was prescribed without the monitoring requirements, prescribing restrictions and warning label obligations that Schedule 4 status imposes. It was available in states without their own scheduling laws as a fully unrestricted prescription drug. It was diverted, combined with opioids, and documented in overdose death throughout a period when the regulatory apparatus that might have slowed its distribution was in the process of building its evidentiary case. The DEA and FDA operated within the legal and procedural constraints of the scheduling system as it was designed. The system was designed to be careful. Being careful has costs that are not always visible in the paperwork. They tend to show up instead in toxicology reports. Because federal scheduling took so long to arrive, the response to Soma abuse became a fragmented state-by-state experiment. Some states moved aggressively and early. Others barely moved at all. Texas added carisoprodol to its controlled substances list in 2010. Florida, which had become a national epicenter for pill mill activity, added it in 2012, the same year as the federal action. Alabama, Kentucky, and other high-impact states had varying timelines and enforcement mechanisms. The patchwork system created predictable consequences. When a state adds a drug to its controlled substance list, it changes the regulatory environment within that state in meaningful ways. Prescriptions require more documentation. Monitoring programs gain visibility into prescribing patterns. Pharmacies apply additional scrutiny to scripts. Prescribers face greater liability for questionable practices. These changes don't eliminate abuse. The history of controlled substance policy is the history of abuse finding new channels. But they do raise the friction, and raising the friction matters at the margins. What the patchwork system also created was a pressure gradient. When Florida began seriously enforcing against pill mills in 2011 and 2012, what happened was not that the demand for Soma, opioids, and benzodiazepines disappeared. It moved. States with less restrictive environments and less developed prescription monitoring infrastructure found themselves on the receiving end of prescription tourism that had previously flowed into Florida. Kentucky and Tennessee saw increases in certain prescription drug metrics that track the timing of Florida's crackdown with a precision that was too consistent to attribute to coincidence. This is the hydraulic reality of uneven drug regulation. You squeeze one place and the problem flows somewhere else. It doesn't disappear, it relocates. The appropriate response to a hydraulic problem is not to squeeze one place harder, but to address the whole system simultaneously, which is what federal scheduling combined with mandatory prescription monitoring programs and coordinated enforcement was theoretically designed to accomplish. The theory was sound. The implementation timeline allowed a great deal of flowing to occur before the whole system was addressed. The states that acted early deserve credit for making a difficult regulatory decision before the federal consensus had formed. Texas scheduling Soma in 2010 required the state legislature to make a determination that diverged from the then current federal classification. Florida's pill mill crackdown, which involved legislation, enforcement action, and significant political will, demonstrably reduced prescription drug overdose deaths within the state, at the cost, initially, of displacing the problem to neighbouring states, but eventually as part of a broader tightening of the national prescribing environment. The lesson from the patchwork response is not that federal uniformity is always superior to state action. It's that state action, without federal coordination, produces uneven results that benefit the states that move first and impose costs on the states that receive the displaced demand. And in a crisis driven by pharmaceutical distribution, a supply chain that crosses state lines as routinely as the trucks that stock the pharmacy shelves, the geography of the response has to match the geography of the problem. For every patient who sought Soma recreationally or for purposes of resale, there was another who had simply been prescribed it by a well-meaning doctor, taken it as directed, and found themselves physically dependent through no particular fault of their own. These patients occupy an awkward space in the addiction narrative, too compliant to fit the street drug story, too dependent to simply stop, and they were often poorly served by a medical system that had no consistent protocol for weaning them off a drug it had never adequately warned them about. The legitimately prescribed, therapeutically dependent patient is the figure the Soma story is most uncomfortable accommodating. The framework most commonly used to address prescription drug crises is organised around identifying bad actors, the pill mill physician, the fraudulent patient, the diversion network. This framework is useful for enforcement, but inadequate as a clinical response, because it systematically misidentifies the patient who followed every rule and still ended up dependent. That patient didn't game the system failed them, and the two failures required different remedies. What did these patients look like? They were, in many cases, long-term chronic pain patients who had been on carisoprodol for years, sometimes from an era when the drug was routinely prescribed for indefinite duration, sometimes as a result of prescription renewals that nobody thought to question. They were often elderly, often female, often managing multiple comorbidities with multiple medications. They were the kind of patients for whom a conversation about tapering was genuinely complicated by the real risk that discontinuing their muscle relaxer would worsen the underlying pain that it had been partially addressing. Their prescribers, when confronted with the scheduling change in 2012, faced a genuine clinical dilemma. The drug was now a controlled substance. Prescribing it required additional documentation, monitoring, and justification. But the patient in front of them had been taking it for years, without escalating their dose, without obvious signs of misuse, and with real functional benefit. Abruptly stopping the prescription was medically inadvisable. Continuing it required navigating a regulatory framework designed for a different kind of prescribing relationship. The standard of care for managing carisoprodol dependence in these patients, slow tapering, potentially in combination with other medications to manage withdrawal symptoms, with close clinical monitoring, was not widely disseminated, not consistently applied, and not well reimbursed. Patients who needed help stopping a medication their doctor had started often couldn't get that help through the same medical system that had prescribed the drug. Addiction medicine specialists were scarce. Pain management specialists had varying levels of comfort with the problem. Primary care physicians were left managing a complicated discontinuation without adequate support. These patients fell through the gap between the drug's past and its regulatory present. They were the cost of reclassification that arrived, correctly, too late. Paid not by the institutions that delayed the scheduling, not by the pharmaceutical companies whose marketing had obscured the dependence liability, but by the individuals whose bodies had simply adapted, without their knowledge or consent, to a chemical they had been told was safe to take indefinitely. Among the populations with disproportionately high rates of Soma use and misuse, veterans with service-related musculoskeletal injuries occupy a particularly painful corner. The physical demands of military service, carrying heavy loads, absorbing impact, sleeping in conditions that would destroy a civilian spine in a month, mean that chronic back and muscle pain is nearly endemic in returning service members. The VA's prescribing culture, for a period, was not meaningfully different from the civilian pain clinic ecosystem. The body's accounting of military service is specific and cumulative. A soldier carrying a 60-pound pack over uneven terrain for years accumulates spinal compression that doesn't announce itself immediately, but arrives, reliably, in the years following service. The adrenaline and physical conditioning of active duty mask a great deal. The transition out of service into a more sedentary civilian life is often when the accumulated damage makes itself fully known. The back that held through 3 deployments begins to speak at 35, and it speaks loudly. The VA healthcare system, which serves millions of veterans, has been the subject of sustained scrutiny regarding its prescribing practices. For much of the 2000s, the VA's pain management approach leaned heavily on opioid prescribing, a pattern that generated significant congressional and journalistic attention. Carisoprodol's role in VA prescribing received less attention but was not absent. The drug appeared in VA formularies, was prescribed to veterans with musculoskeletal complaints, and interacted with the opioid prescriptions many of those same veterans were receiving in exactly the ways the pharmacology predicts. Veterans face additional risk factors that compound the carisoprodol dependence picture. Rates of PTSD and other trauma-related conditions are elevated in combat veterans, and conditions that affect sleep, anxiety, and pain. Amplification intersect with carisoprodol's meprobamate's metabolite in ways that create both greater clinical rationale for the drug and greater dependence liability. The calming, sleep-inducing effects of the drug are not irrelevant to a population with high rates of hyperarousal and sleep disturbance. They are, in fact, precisely the effects that make the drug appealing and that make stopping it difficult. Underreporting in this population is compounded by the cultural dimensions of military service. The reluctance to acknowledge medication dependence, framed in military culture as a form of weakness or loss of control, means that veterans who were experiencing problematic use were less likely than civilian patients to self-report and seek help. The same stoicism that makes military culture functional in a combat environment creates barriers to accessing care for problems that require acknowledging vulnerability. The VA has over time implemented more robust prescription monitoring, tightened carisoprodol prescribing guidelines, and invested in non-pharmacological pain management approaches including physical therapy, chiropractic care, and acupuncture. These changes represent genuine improvement. They also arrived after a period during which veterans, people who had already paid a significant physical price for their service, were handed a medication whose dependence liability was insufficiently disclosed and asked to manage the consequences largely on their own. Pharmacology has a word for what happens when two CNS depressants are combined and their effects multiply beyond simple addition: synergy. In the context of respiratory depression, the mechanism by which opioid overdoses kill, synergy is not a marketing term. It's a body finding its way to a threshold it wasn't supposed to reach. Carisoprodol, converted to meprobamate, enhances the sedative effects of opioids in a way that significantly lowers the dose at which breathing becomes dangerously suppressed. The respiratory drive is a system with redundancy built in. Under normal conditions, the brainstem monitors carbon dioxide levels and adjusts breathing rate automatically. You don't have to remember to inhale. Opioids act on mu receptors in the brainstem to blunt this automatic response. At therapeutic doses, the blunting is manageable. At higher doses, or in a person whose respiratory drive has been additionally suppressed by another CNS depressant, the automatic breathing response becomes unreliable. The carbon dioxide rises, the blood oxygen falls. The brainstem that was supposed to notice and respond has been pharmacologically quieted past the point of adequate response. Meprobamate, as a GABA-enhancing compound, contributes to this suppression through a different receptor pathway. It doesn't act on mu receptors. It doesn't directly suppress the brainstem's opioid response. What it does is reduce the overall level of CNS activity in a way that lowers the threshold at which the opioid's respiratory effects become dangerous. A dose of oxycodone that a tolerant user handles without respiratory compromise may, in the presence of elevated meprobamate levels, produce exactly the respiratory compromise it would not have produced alone. The opioid is the same, the dose is the same. The system it's acting on has been changed. This mechanism is not exotic or poorly understood. It's the same synergistic mechanism that makes alcohol and benzodiazepines dangerous in combination with opioids, a fact that has been established in the pharmacological literature for decades and is routinely communicated in clinical training and drug labeling. What was not routinely communicated, what required years of advocacy, accumulating death data, and eventual scheduling action, was that carisoprodol belonged in the same conversation. The practical consequence is that the overdose risk calculation for any patient taking both Soma and an opioid is not the sum of two separate risk profiles. It is something larger than that sum, and how much larger depends on dose, duration, individual metabolism, and the presence of other substances. Alcohol, which also enhances GABA activity, adds a third variable. A person who takes their Soma with their hydrocodone and has a few drinks in the evening has stacked 3 CNS depressants with overlapping mechanisms of respiratory suppression. Their risk is not their baseline risk, plus Soma's risk, plus the drink's risk. Their risk is a compound function of all three, and it is substantially higher than any straightforward addition would suggest. The people who died from Holy Trinity combinations were not, in most cases, taking deliberately lethal doses. They were taking their prescriptions. They were managing their pain. They were doing what their doctors had arranged for them to do, in a combination that their doctors had not adequately explained was dangerous, with substances that their pharmacies had not been equipped to flag as a problematic combination until the monitoring infrastructure caught up. The mechanism that killed them was understood. The warning that might have saved them was delayed. That gap is the story. Compared to the cultural saturation of OxyContin, the literary romanticism of heroin, or the political lightning rod of crack cocaine, Soma barely registered in popular consciousness. There were no films centered on it. No memoirs defined a generation's relationship with muscle relaxers. It moved through communities quietly, tucked into the same prescription bags as the more famous drugs, rarely the protagonist of its own story. This cultural invisibility is itself revealing. The drugs that generate cultural response, that produce films, memoirs, legislation named after victims, congressional hearings with weeping parents, tend to be drugs whose users and victims are visible. The heroin epidemic had a face. The crack epidemic had a face, and the politics of whose face it was shaped a great deal of what came next. OxyContin generated dopesick, generated painkiller, generated a Sackler family reckoning that ran through civil courts and cultural discourse for decades. Soma generated largely nothing. Part of this is the nature of the population most affected. Soma's heaviest casualties were concentrated in rural, economically marginalized communities in the American Southeast, populations that have historically generated less cultural representation than they deserve. The middle-aged white construction worker dying of a polydrug overdose in rural Kentucky in 2006 was, in the cultural production terms of that era, largely invisible. The crisis wasn't invisible to the people living inside it. It just didn't translate into the kind of cultural output that reshapes public perception and drives policy response. Part of it is also the drug's character. Soma doesn't produce dramatic intoxication in the way that more culturally prominent substances do. It doesn't generate the visual signature of heroin, the nod, the physical deterioration, the specific aesthetic that cinema has used to represent addiction for decades. A person taking Soma looks, largely, like a person who took something that made them feel calmer and heavier. The dependence is quiet. The withdrawal is invisible. The overdose, when it happens, is attributed to the other drugs in the system. Soma doesn't make for good footage. The Huxley reference embedded in the brand name went largely unremarked in public discourse. This is genuinely strange if you think about it. A pharmaceutical company named its product after a government happiness drug in a dystopian novel about a society where pharmacological compliance had replaced genuine freedom. And for decades, nobody in the cultural commentary space made much of this. The name was there. The irony was structural. The cultural engagement never quite arrived. What Soma's cultural silence cost is harder to quantify than what its pharmacological misclassification cost, but it's real. Drugs that enter public consciousness generate public scrutiny. Public scrutiny generates regulatory pressure. Regulatory pressure generates the structural changes, warning labels, prescribing restrictions, monitoring programs that slow the harm. The drugs that stay invisible stay dangerous longer. Soma was, in this sense, almost perfectly designed for institutional neglect. A drug with a quiet dependence profile, a population of victims with limited cultural representation, and a name from a novel nobody in the relevant conversation had apparently read. Not every physician who prescribed carisoprodol liberally was running a pill mill. Many were practitioners working in good faith within a medical consensus that had consistently minimized the drug's addiction liability. The literature said low abuse potential. The pharmaceutical rep said safe and well tolerated. The patient in the exam room had a real injury and a real need for relief. The 15-minute appointment did not easily accommodate a nuanced conversation about meprobamate metabolites. The good faith prescriber is a figure that gets lost in the forensic history of pharmaceutical crises. The pill mill physician, the one who wrote prescriptions without examining patients, who ran cash-only operations out of strip malls, who knew exactly what they were doing and did it anyway, is comprehensible as a villain. The enforcement response has a clear target. The moral accounting is straightforward, but the majority of carisoprodol prescriptions were not written by pill mill physicians. They were written by family doctors, general practitioners, and orthopedic specialists who had been trained in an environment that treated carisoprodol as a routine, low-risk intervention for a common condition. What these physicians were working from was a pharmacological knowledge base shaped substantially by the pharmaceutical industry's own characterization of the drug. Continuing medical education, which physicians rely on to stay current after formal training, has historically been substantially funded by pharmaceutical manufacturers. Drug representatives visited offices with samples and literature that emphasized efficacy and minimized dependence risk. The clinical guidelines that most prescribers consulted when treating back pain did not, for most of carisoprodol's history, include prominent warnings about the meprobamate conversion or the dependence profile. A prescriber doing their diligent best within the information environment that existed was capable, in perfectly good conscience, of continuing to prescribe Soma in ways that were contributing to patient harm. This doesn't exonerate the prescribers who ignored obvious warning signs, the patients requesting early refills, the combination patterns that match the Holy Trinity profile, the patients who became agitated when the drug was unavailable. Clinical judgment is part of the job, and the warning signs were visible to practitioners who were looking. But the distribution of responsibility across the Soma crisis is not cleanly divided between careful doctors and careless ones. It runs through a medical education system that trained people on an incomplete pharmacological picture, a regulatory classification that provided false assurance, a pharmaceutical marketing environment that amplified that assurance, and a healthcare delivery structure that rewarded brief appointments and pharmacological solutions over the time-intensive alternatives. The prescribers who bear the most straightforward moral responsibility are the ones who did know and continued anyway, the ones who recognized the pill mill dynamic they were running, who understood that their prescribing patterns were not defensible clinically, and who chose financial gain over patient welfare. Those physicians exist, were prosecuted in some cases, and represent a genuine failure of professional ethics. But they are not the whole story. The much larger and more diffuse story is the one about a medical system that created conditions under which well-intentioned physicians caused widespread harm, and that took decades to change the information environment that made that harm possible. One of the structural changes that most directly affected carisoprodol prescribing patterns was the gradual expansion and mandatory adoption of prescription drug monitoring programs, state-run databases that track controlled substance prescriptions in real time. When a pharmacist can see, before dispensing, that a patient has filled carisoprodol at 4 different pharmacies in the past 30 days, that information transforms a pattern-based suspicion into a documentable clinical finding. It gives the pharmacist something to point to. It gives the refusal a basis, and it shifts the professional burden from the pharmacist's judgment to the data itself. The concept behind prescription monitoring programs is straightforward. If every controlled substance prescription is entered into a centralized database at the point of dispensing, any authorized user, prescriber, pharmacist, or state regulatory authority can see the complete prescription history of any patient in the system. Doctor shopping, the practice of visiting multiple providers to obtain overlapping prescriptions, becomes immediately visible. Early refills appear as data anomalies. The Holy Trinity combination shows up as a pattern that any prescriber can see before writing their piece of it. In practice, the implementation was messier than the concept. Prescription monitoring programs are state-run systems, which meant that interstate data sharing required formal agreements between states, agreements that took years to negotiate and implement. a patient filling prescriptions in Kentucky, crossing into Tennessee for additional scripts, and driving to Virginia for a third set was not fully visible in any single state's database until interoperability agreements made cross-state queries possible. The infrastructure had to be built piece by piece, state by state, over a period when the problem it was designed to address was already at scale. Mandatory query requirements, rules that required prescribers and pharmacists to check the database before prescribing or dispensing certain controlled substances, were not universal. In states with voluntary use systems, the monitoring program existed, but was only as effective as the adoption rate. Prescribers who didn't check didn't know. And checking took time, not much time, but in a busy primary care practice seeing 30 patients a day, even a brief additional step per patient created friction that many providers found ways to minimize. The evidence on prescription monitoring program effectiveness, once mandatory query requirements were widely implemented, is reasonably clear. States with robust mandatory programs saw reductions in controlled substance prescribing, reductions in prescription opioid overdose rates, and reductions in the metrics associated with prescription drug diversion. The technology worked when it was required to be used. In a system comprehensive enough to capture the prescribing patterns it was designed to expose. Carisoprodol's addition to the Schedule IF list in 2012 meant that it entered the monitoring systems, that the drug that had been invisible to the tracking infrastructure for decades finally appeared in the data. The prescription monitoring program story is one of the cleaner successes in the pharmaceutical regulatory response to the opioid and related drug crisis. Not perfect. The lag in implementation, the interstate gaps, the years of voluntary-only systems, but directionally correct, evidence-based, and ultimately effective. It is also a reminder that the tools for addressing prescription drug harm are not mysterious. They involve visibility, accountability, and the institutional will to require that the people making prescribing decisions see the information that makes bad decisions impossible to defend. Federal scheduling and prescriber education reduced new carisoprodol prescriptions significantly after 2012. But they did not eliminate them, and more importantly, they did nothing for the patients who had already been taking the drug for years or decades. These legacy patients exist in a medical grey zone that their prescribers find genuinely uncomfortable. Tapering them off risks reactivating the pain that justified the prescription in the first place. Continuing the prescription now carries the regulatory weight of a Schedule IV controlled substance. Consider the position of a patient who had been prescribed Soma for chronic back pain since 2002 and is now sitting in their doctor's office in 2013. They are, by any reasonable clinical measure, dependent on the drug. They have tried stopping twice and experienced withdrawal symptoms severe enough to return them to the prescription. The pain that justified the initial prescription is still present, though it is now impossible to know how much of the pain they experience in the drug's absence is original pain, and how much is withdrawal-mediated hyperalgesia, a phenomenon in which physical dependence on CNS depressants actually amplifies the perception of pain during abstinence, creating a cruel pharmacological loop where the treatment has made the underlying condition functionally worse to endure without it. Their spine is the same spine it was in 2002. Their pharmacology is not. The prescriber in this situation has legitimate options, none of them comfortable. A supervised taper, conducted slowly over several months, is the standard of care recommendation, but it requires time, frequent check-ins, and patient cooperation sustained over a duration that most clinical encounters aren't structured to support. A patient who is tapering from a CNS depressant needs to be monitored for withdrawal symptoms, needs their pain levels tracked, and needs a support structure during what is often a genuinely difficult several months of their life. That support structure is not automatically available in a primary care practice already running behind schedule. Referral to an addiction medicine specialist is appropriate, but faces the practical barriers of specialist availability, insurance coverage, and critically, patient resistance to a referral that implies their problem is an addiction rather than a pain condition. The semantic distinction matters enormously to patients who have been taking their prescription exactly as directed and do not understand why they are being referred to services they associate with street drug use. Continuing the prescription with enhanced monitoring is defensible in some cases, but creates ongoing regulatory and clinical exposure. The prescriber writing a long-term carisoprodol prescription for a legacy patient after 2012 is working under scrutiny that their predecessors never faced. The same prescription that would have been written without comment in 2005 now appears in a prescription monitoring database, triggers pharmacy alerts in some systems, and requires documentation that the prescriber has considered the alternatives. None of this is unreasonable. All of it adds friction to a clinical relationship that was not designed with this complication in mind. The legacy patient population skews older, skews female, and skews toward the demographics most associated with chronic musculoskeletal conditions. The same demographics, in other words, that the drug was most commonly prescribed to across its peak prescribing years. An elderly woman who has been taking carisoprodol since her 60s, who is now in her late 70s, who takes other medications that interact with CNS depressants, and whose fall risk is already elevated by age and arthritis, represents a clinical situation that requires a level of individualized attention the healthcare system often struggles to provide. Her dependence may be quiet, her tolerance may be stable, but a pharmacological vulnerability to the drug's sedating effects increases with age, and the combination of carisoprodol with the other medications she's almost certainly taking, antihypertensives, other pain medications, sleep aids, creates a risk profile that her original prescriber could not have fully anticipated. The healthcare system's response to legacy patients has been, characteristically, uneven. Some prescribers managed careful, well-monitored tapers with good outcomes. Some abruptly discontinued prescriptions when the scheduling change made continued prescribing feel legally uncomfortable, leaving patients to manage withdrawal without adequate clinical support, an outcome that is both medically inadvisable and, in documented cases, medically dangerous. Some continue prescribing without meaningful reassessment, because changing a stable regimen carries its own risks, and the path of least resistance is sometimes the clinically reasonable one. No single approach was universally applied because no uniform protocol existed, and filling that protocol gap was not a priority for a healthcare system simultaneously managing the opioid crisis, the aftermath of the Affordable Care Act, and approximately every other competing demand on primary care physician bandwidth. There is no clean answer for the legacy patient, and the absence of a clean answer reflects the accumulated cost of decisions, regulatory, pharmaceutical, and clinical, that preceded their predicament. They didn't create this situation. They were placed in it by a sequence of institutional failures that operated at a scale far above the individual prescription. The reckoning for those institutional failures has largely been conducted through policy, litigation, and public health debate. The legacy patient is managing the personal residue of that reckoning in a doctor's office, one uncomfortable appointment at a time. What the legacy patient represents, more than anything else in this narrative, is the irreversibility of certain pharmaceutical decisions. You can schedule a drug, you can restrict prescribing, you can implement monitoring and mandate queries and educate practitioners. What you cannot do is reach back into the bodies of the people who are prescribed a drug under false assurances and undo the adaptation that their nervous systems have already performed. The biology doesn't respond to regulatory actions, it responds to chemistry, and the chemistry was already done. The legacy patient is living proof that the cost of getting a classification wrong is not paid at the moment of the error. It is paid over decades, in doctors' offices, in the bodies of people who had no part in making the decision, and no recourse but to manage its consequences as best they can. Carisoprodol is still prescribed in the United States. The number of prescriptions has declined substantially from peak levels, but it remains a legally available, pharmacologically active option for short-term musculoskeletal pain. in patients for whom other options have been inadequate. The prescribers writing those prescriptions are doing so with more information, more monitoring infrastructure, and more regulatory accountability than the prescribers of 20 years ago. Whether that represents adequate progress is a question the legacy patients, living inside the gap between what was known and what was done, are probably best positioned to answer. When carisoprodol prescriptions declined, the patients who had relied on them for back and muscle pain didn't simply recover and move on. They were redirected toward other muscle relaxants, toward increased opioid doses, toward over-the-counter combinations that their bodies hadn't been trained on, and in some cases toward nothing at all. The question of whether Soma's effective replacements were meaningfully safer is not one that resolves neatly. The muscle relaxant category is not monolithic. It contains drugs with substantially different mechanisms, different side effect profiles, and different dependence liabilities. Cyclobenzaprine, sold as Flexeril, is among the most commonly prescribed alternatives, a structurally tricyclic compound with sedating properties that has its own documented concerns in long-term use, particularly in older adults whose anticholinergic burden, the cumulative sedating and cognitively impairing effect of the multiple medications, is already a clinical concern. Cyclobenzaprine works. It also causes dry mouth, urinary retention, cognitive dulling, and falls in elderly patients. Trading carisoprodol for cyclobenzaprine in a 70-year-old with polypharmacy is not obviously a safety improvement. It is a lateral move between imperfect options. Methocarbamol and metaxalone have different pharmacological profiles and lower documented dependence liability, but also less robust evidence of efficacy for chronic pain. They tend to produce less sedation, which is both a safety advantage and a clinical limitation. Some of the pain relief that patients attributed to carisoprodol was, almost certainly, attributable to sedation. A drug that produces less sedation produces less of that effect, and patients who are used to the heavier, more enveloping relief of carisoprodol frequently found the alternatives inadequate. This is not drug-seeking behavior in the pejorative sense. It is a patient reporting, accurately, that a substitute is not producing the same therapeutic outcome as the original medication. Baclofen, which acts on GABA B receptors and was originally developed for spasticity in neurological conditions, has been used off-label for musculoskeletal pain and has its own complicated relationship with misuse and dependence. Its abuse potential has been documented particularly in populations with concurrent alcohol use disorders, where its GABAergic mechanism produces an effect profile that interacts with alcohol dependence in ways that have generated both clinical concern and, ironically, research interest in its therapeutic applications for alcohol withdrawal. Substituting baclofen for carisoprodol in a patient who also drinks is not a straightforward risk reduction. The non-pharmacological alternatives deserve serious engagement rather than the perfunctory endorsement they typically receive in narratives about pharmacological excess. Physical therapy, when properly prescribed and adequately followed, produces durable improvements in functional capacity and pain reduction for most forms of chronic musculoskeletal pain. The evidence base is substantial. The mechanism is sound, strengthening the muscles that support a damaged structure, improving movement patterns that distribute load more appropriately, addressing the psychological components of chronic pain that amplify the physical experience. These are not placebo effects. They are real biological changes produced by real physical intervention. The problem is not the evidence. The problem is the delivery. Physical therapy requires that a patient attend multiple sessions per week for several weeks, potentially longer. It requires transportation to a facility. It requires insurance authorization, which varies by plan and by diagnosis. It requires a body that is capable of participating in therapeutic exercise, a qualification that is not universal in a chronic pain population that frequently includes people with significant deconditioning, obesity, comorbid conditions, and pain levels that make movement itself aversive before the therapy has had time to work. And it requires a healthcare system willing to invest in a 6-week course of treatment that produces gradual improvement rather than a prescription that produces immediate relief and generates a refill a month later. The incentive structures don't align. They haven't aligned. They continue not to align. Some patients redirected away from carisoprodol found that their pain increased and their function decreased in ways that led their prescribers, or themselves, toward increased opioid doses. This is one of the less tracked and more consequential downstream effects of Soma's decline. The degree to which removing a component of a multi-drug pain management regimen, without replacing it with something of equivalent efficacy and better safety, may have contributed to opioid escalation in some patients. When carisoprodol was part of the Holy Trinity, it was the element that potentiated the opioid. It made the opioid feel like more. When it was removed, the opioid felt like less. Some patients and prescribers responded by increasing the opioid to compensate. The data on this specific dynamic is not comprehensive, but the clinical logic is straightforward, and practitioners who manage this transition describe it with the weary recognition of people who have watched an intended improvement produce an unintended consequence. The search for what should replace Soma leads eventually back to the same destination that every pathway in this narrative eventually reaches, the underlying problem of chronic pain as a medical condition that the American healthcare system treats inadequately, expensively, and too often pharmacologically by default. The replacements for carisoprodol are imperfect because the problem carisoprodol was addressing was never adequately solved. It was managed with varying degrees of harm, using the tools that were fastest and most financially viable in a system that was not designed for the long, slow, multidisciplinary work that chronic pain actually requires. Soma filled a gap. The gap is still there. The question of what should fill it is not primarily a pharmacological question. It is a structural one, and the structure hasn't changed enough to answer it well. The corporate history of carisoprodol involves a degree of institutional memory about the drug's abuse potential that became increasingly difficult to reconcile with decades of marketing language. Internal documents and litigation have, over the years, revealed that concerns about dependence and the meprobamate metabolite were not entirely absent from the conversation inside pharmaceutical companies. The degree to which that knowledge influenced, or failed to influence, labeling, marketing, and regulatory communication is a question still being answered, and the answer, in its most charitable framing, is insufficiently and too slowly. Wallace Laboratories, which developed and initially marketed Soma, operated in a regulatory environment substantially different from today's. The 1950s pharmaceutical landscape was one in which the burden of demonstrating harm before restricting a drug was higher. The reporting requirements for adverse events were less formalized, and the flow of information from clinical practice back to the manufacturer and regulator was slower and less systematic. A drug could be on the market for years before the accumulation of adverse event reports reached a volume sufficient to generate regulatory attention, and in the absence of that attention, manufacturers had limited structural incentive to proactively investigate and publicize risks that hadn't yet become a regulatory problem. This is not a defense of the system. It is a description of the environment in which decisions were made that would have consequences for decades. The company that eventually acquired and continued marketing carisoprodol, through the pharmaceutical industry's characteristic sequence of mergers, acquisitions, and brand transfers, was Meda Pharmaceuticals, later acquired by Milan, which became Viatris. This chain of corporate succession creates a particular kind of accountability diffusion. The decisions about labeling, marketing, and regulatory engagement made by Wallace Laboratories in the 1960s were made by people who are no longer employed by entities that no longer exist under their original names. Tracing institutional responsibility across 50 years of pharmaceutical mergers is a legal and historical exercise that resists clean resolution. The drug persisted. The company that sold it changed. The accountability framework that might have imposed costs for early decisions had, by the time it became relevant, a very complicated question of who to hold responsible. What the pharmaceutical industry defense in cases like this typically argues runs along three parallel tracks. First, the company acted on the information it had at the time, and the information available in the 1950s and 60s was genuinely incomplete by the standards of later pharmacological research. Second, the regulatory process that approved the drug without scheduling it represented an implicit institutional validation of the low dependence characterization. If the FDA didn't require scheduling, the FDA's experts had presumably reviewed the evidence and found it insufficient to meet the scheduling threshold. Third, prescribing decisions are ultimately the professional responsibility of licensed physicians, who have independent obligations to their patients that exist separately from the manufacturer's marketing communications. Each component of this defense has partial merit and significant limitations. The first is true in a narrow sense, and misleading in a broader one. The meprobamate connection was known from the drug's earliest characterization, and the dependence liability of meprobamate had been documented before the scheduling change occurred. The information about the metabolite was available. The decision to treat that information as insufficiently alarming to require prominent warning label language was a choice made by people with access to relevant data. The second is a misreading of how regulatory approval works. FDA approval establishes that a drug has demonstrated sufficient efficacy and acceptable safety for its labeled use, not that all possible risks have been fully characterized and disclosed. Approval is a threshold finding, not a certification of safety. The third confuses the prescription decision with the information environment that shapes it. A physician who's been consistently told, through the channels of continuing medical education and pharmaceutical marketing, that a drug has low abuse potential is making their prescribing decisions within an information environment that the manufacturer helped construct. The litigation that has accumulated around prescription drug crises, most notably the OxyContin cases, the Purdue Pharma bankruptcy, and the Sackler family settlements, has established a legal and cultural framework for examining what pharmaceutical companies knew, when they knew it, and what they said and didn't say to the prescribers and patients whose behavior their communication shaped. The Soma story has not generated litigation at that scale. The manufacturers of carisoprodol were not as dominant, as visible, or as specifically implicated in aggressive misleading marketing as Purdue Pharma was. The harm was more diffuse, the corporate lineage more complicated, the specific instances of knowing misrepresentation less dramatically documented. The calculus for large-scale pharmaceutical litigation, which requires a financially viable defendant, a clear theory of knowing misconduct, and a damages framework that courts will sustain, did not align for carisoprodol in the way it aligned for OxyContin. But the absence of major litigation is not the same as the absence of corporate responsibility. The Soma story is one in which a pharmaceutical product was marketed for decades in a way that shaped the prescribing culture, suppressed clinical alarm, and delayed the regulatory reckoning that the pharmacological evidence supported. That marketing didn't cause the back pain that generated the prescriptions. It didn't create the inadequacy of the healthcare system's chronic pain management infrastructure. But it contributed to a clinical environment in which a drug that was causing measurable harm was treated as benign for longer than the evidence warranted. That contribution is real, even in the absence of a Purdue-scale legal reckoning. The people who were harmed by it were harmed regardless of whether the legal system ever adequately accounted for the role the pharmaceutical industry played in creating the conditions for that harm. Soma's trajectory from wonder drug to controlled substance is, at some fundamental level, a story about chronic pain and how poorly the American medical system has ever dealt with it. Chronic musculoskeletal pain is extraordinarily common, often inadequately understood, rarely cured, and enormously expensive to manage. The pharmaceutical solution, prescribe something for the hurting, has always been faster, cheaper, and more reimbursable than the non-pharmaceutical alternatives. Until that changes, The specific drug at the center of the next crisis is less important than the structural conditions that will elevate it. Chronic pain is, by clinical definition, pain that persists beyond the expected period of healing, typically defined as 3 months or more. It affects an estimated 50 million American adults in some form, with roughly 20 million experiencing high-impact chronic pain that limits daily function. These are not small numbers. They represent a population larger than the entire country of Canada, living with a condition that medicine treats inconsistently, inadequately, and often in ways that create secondary harms that compound the original problem. The opioid crisis is the most visible of those secondary harms. Carisoprodol is another. Benzodiazepine overprescribing in pain patients is another. The pattern is not a series of isolated pharmaceutical failures. It is the recurring expression of a structural problem. The biological complexity of chronic pain is real and should not be dismissed. Acute pain, the pain of a fresh injury, is a relatively straightforward signal. Tissue is damaged, nociceptors fire, the brain registers danger, behavior changes to protect the damaged area. Chronic pain is categorically different. In many chronic pain conditions, the peripheral tissue is healed as much as it is going to heal, but the central nervous system has undergone changes, sometimes called central sensitization, that maintain the pain experience independently of ongoing tissue damage. The pain is not imaginary. It is not weakness. It is a maladaptive persistence of neural signaling that has become detached from its original protective function. Treating this kind of pain with a drug that suppresses CNS activity is not illogical. It may provide genuine relief, but it does nothing to address the central sensitization that is driving the experience, and when the drug is removed, the sensitized system is still there, generating the same signals. The psychological dimensions of chronic pain are equally real and equally undertreated. The relationship between depression, anxiety, and chronic pain is bidirectional and well established. Chronic pain increases depression and anxiety amplify the experience of chronic pain. Sleep disruption, which is nearly universal in chronic pain patients, further amplifies both. A patient with chronic back pain who is also depressed, anxious, and sleep deprived is experiencing a condition that requires a comprehensive intervention addressing all of those dimensions simultaneously. They are almost never receiving that intervention. They are almost always receiving a prescription for something that addresses one dimension, the pain, in a way that may temporarily help the sleep and the anxiety as well, which is precisely why carisoprodol felt so effective to so many patients and so difficult to discontinue. The healthcare system's incentive structure has been discussed throughout this narrative, but it deserves direct attention here because it is the mechanism through which the larger failure perpetuates itself. The United States spends more on healthcare per capita than any other developed nation and achieves worse outcomes on most population health metrics than most of its peer countries. Chronic disease management, which is where chronic pain sits, is an area of particular underperformance. The system reimburses procedures more generously than it reimburses time, reimburses acute intervention more generously than preventive care, and creates primary care physicians whose financial survival depends on patient volume in a way that is structurally incompatible with the time-intensive management that chronic conditions require. A primary care physician managing a chronic pain patient well, assessing the functional impact, coordinating physical therapy, screening for depression, reviewing the medication regimen, monitoring for dependence, discussing non-pharmacological coping strategies, is spending 30 to 45 minutes on an encounter that the billing system will reimburse at roughly the same rate as a 10-minute acute visit. The financial incentive is to see more patients for less time. The clinical imperative is to spend more time with fewer patients. That tension is not resolvable at the level of individual physician behavior. It requires systemic change in how chronic disease management is defined, valued, and compensated. Non-pharmacological chronic pain management, The approaches that the evidence increasingly supports as more durable and less harmful than long-term pharmacological suppression is systematically under-resourced. Interdisciplinary pain programs, which combine physical rehabilitation, psychological intervention, and medical management in a coordinated framework, have the strongest evidence base for chronic pain outcomes, but are rare, expensive, and inconsistently covered by insurance. Cognitive behavioral therapy for chronic pain, which has robust evidence of efficacy, requires mental health coverage, provider availability, and patient engagement over a timeline that the acute care orientation of most healthcare encounters doesn't support. Mindfulness-based interventions, exercise therapy, and occupational rehabilitation all have evidence behind them and access barriers in front of them. Soma did not fail because the people who developed it, prescribed it, and took it were stupid, careless, or malicious, though some of each were involved at various points. It failed because it was a pharmacological solution deployed in a structural vacuum. The structural problem, the inadequacy of chronic pain management in the American healthcare system, has not been solved. The drug that fills the vacuum next will be different. The narrative that surrounds it will be familiar. And until the healthcare system builds genuine infrastructure for treating chronic pain, without defaulting to suppression as the first and easiest response, the names on the bottles will change and the story will not. There's a particular kind of cultural penetration a drug achieves when it develops its own regional slang. Soma had it. In parts of the American Southeast, particularly in communities hit hardest by the combination of opioid and muscle relaxer availability, DS, short for Dan 5513, the imprint on one common carisoprodol tablet, became as recognizable as any other piece of local vocabulary. Drug slang is a form of community knowledge. It signals distribution networks, signals shared experience, and signals how normalized a substance has become within the social fabric of a place. When a drug has a nickname that everyone in a particular county understands without explanation, that drug has crossed a threshold of cultural integration that formal surveillance systems frequently fail to capture until years after the fact. The sociology of drug slang is worth taking seriously as an epidemiological data source, not as a curiosity. Formal surveillance systems, emergency department records, treatment admission data, prescription monitoring databases track drug use with a lag that can measure in years between the emergence of a pattern and its appearance in the data that informs policy responses. Street slang tracks in real time, with a granularity and geographic specificity that no formal system replicates, because it is generated by the communities where use is occurring in response to specific products circulating in specific places through communication channels that are immediate and unmediated. When a drug develops multiple regional names independently, when DS appears in Kentucky and Dance appears in Tennessee, and Somas appears in Alabama without coordinated communication between the people using those terms, that convergent naming is evidence of a drug that has achieved simultaneous widespread distribution across a geographic region. That is significant intelligence. It just doesn't arrive in formats that regulatory bodies are accustomed to processing. The specific etymology of DS is worth unpacking because it illustrates how street nomenclature develops. The Dan 5513 imprint appears on a commonly manufactured generic carisoprodol tablet, a combination of the manufacturer's identifier and the product code, printed on the pill surface as required by FDA drug identification regulations. Someone, somewhere along the distribution chain, noticed this imprint, abbreviated it, and the abbreviation spread through word of mouth until it became the default regional term. The drug's street name, in other words, was generated directly from its federally mandated labeling. There is something almost poetic about a drug that traveled from pharmaceutical regulation to street culture carrying the FDA's own identification mark as its nickname. The opacity of the slang to outsiders was, from the perspective of people using and distributing the drug, functionally useful. Conversations that referenced D's in passing in public settings, in front of people who didn't know what the term meant, didn't trigger the same recognition as conversations about pills or opioids or drugs more generally. A reference to picking up some Diaz sounded like anything. Sounded like nothing. The institutional invisibility that characterized Soma at the pharmacological and regulatory level, the drug that wasn't scheduled, the overdose contribution that was footnoted rather than headlined, the dependence that was misclassified as low risk, was reproduced at the linguistic level in communities where the drug was embedded in daily life. The term encoded both the product and the protection of the product's anonymity, which is a sophisticated adaptive function for a word that nobody consciously designed. Law enforcement's engagement with this linguistic landscape was uneven and delayed by the same factors that delayed regulatory response. Officers working drug enforcement in high-use areas during the peak carisoprodol years describe learning about Diaz and similar terms through informants, through arrest interviews, and through the gradual accumulation of encounters in which the same unfamiliar term appeared. The absence of carisoprodol from the Federal Controlled Substance Schedule until 2012 meant that possession of the drug was not, in most jurisdictions, a straightforward criminal matter regardless of quantity. Street-level enforcement of carisoprodol distribution required establishing either intent to distribute a state-scheduled substance, applicable only in states that had moved ahead of federal action, or connecting the distribution to other controlled substances in a way that could support charges under the laws that did apply. The result was that carisoprodol distribution networks operated with a degree of legal impunity that distribution of equivalent risk scheduled substances would not have enjoyed. The geographic clustering of the slang mirrors, the geographic clustering of the crisis, with a precision that reinforces the earlier analysis of the Southeast Corridor. DS and its variants are documented primarily in Appalachian and southeastern communities, the same communities defined by occupational injury, inadequate healthcare access, economic marginalization, and the intersection of opioid and carisoprodol, prescribing that characterize the Holy Trinity phenomenon. The linguistic geography is not random. Drug slang develops where drug use is concentrated, and drug use concentrates where pain is concentrated, and treatment is inadequate. The map of the slang is the map of the failure. Drug slang also performs social functions that go beyond communication efficiency. It creates in-group boundaries, people who know what DS means and people who don't, that have implications for identity, community, and the social normalization of use. In communities where prescription drug use has become a significant part of daily life, where a meaningful percentage of the population is managing pain or dependence or economic stress through pharmaceutical means, the shared vocabulary of that use becomes woven into social interaction in ways that make the use itself feel ordinary. Not celebrated, not glorified, ordinary. The word doesn't make the drug seem exciting. It makes the drug seem like furniture, like something that's just there, that everyone has a relationship with, that doesn't require explanation because explanation is for things that are unfamiliar. When DS stopped requiring explanation in certain communities, it had stopped being a warning sign and had become a fact of life. And facts of life are considerably harder to address than warning signs, because they require changing not just a prescribing pattern, but a community's relationship to its own pain and to the systems, or lack of systems, that have been offered in response to it. Carisoprodol is still prescribed. That's the first thing to understand about where this story ends, which is to say it doesn't fully end. Schedule V status reduced prescribing, added monitoring, and made the drug harder to obtain casually, but it did not eliminate it from the formulary. Physicians can still prescribe it. Pharmacies still stock it. Patients still take it. The difference is that the system now treats it with at least some of the caution it probably deserved from the beginning, filtered through infrastructure that took decades to build and arrived, after costs were already paid that cannot be recouped. Prescription volumes for carisoprodol declined substantially following the 2012 scheduling action and the associated changes in prescribing culture. The drug that had been among the most commonly dispensed muscle relaxants in the country moved down the formulary hierarchy across most prescribing contexts. Many practitioners stopped writing for it entirely, either because the regulatory weight of Schedule 4 prescribing felt disproportionate for a muscle relaxant, or because the accumulating awareness of its dependence profile had shifted their clinical calculus. Others narrowed their prescribing to specific acute indications, a brief course for a documented acute muscle injury, with explicit conversation about duration and discontinuation in a patient without risk factors for CNS depressant dependence. The casual 30-day prescription for unspecified back discomfort, refilled without question at every monthly appointment, has largely disappeared from clinical practice. Largely. The prescription monitoring infrastructure that now surrounds carisoprodol represents a genuine structural improvement over the environment in which the drug operated during its peak prescribing years. A prescriber writing for carisoprodol today, in a state with mandatory monitoring program queries, is seeing the patient's complete controlled substance prescription history before writing the script. They know whether the patient is already receiving opioids. They know whether a benzodiazepine is in the picture. They know whether the patient has been filling at multiple pharmacies. The information that would have identified the Holy Trinity combination as it was being assembled, information that existed in fragments across multiple prescribers and multiple pharmacies but was never assembled, is now, in most jurisdictions, available at the point of prescribing. The system can see what it couldn't see before. That matters. It matters for new prescriptions. It does not reach backward. The communities most affected by carisoprodol's worst period are not, for the most part, communities that have recovered. The economic conditions that concentrated the crisis in Appalachian and southeastern communities have not transformed. The occupational injury rates in physical labour industries have not dramatically declined. The healthcare access gaps that made pharmaceutical management the path of least resistance for chronic pain in these regions have narrowed in some places and persisted in others. The opioid crisis, which ran parallel to and intersecting with the carisoprodol story, has itself not resolved. In communities where the opioid epidemic is still the dominant public health emergency, the reduced availability of carisoprodol represents one less element in a harmful combination. A meaningful improvement that exists alongside ongoing devastation. There is a particular form of policy melancholy that attaches to the conclusions of pharmaceutical crises, the recognition that the regulatory response, when it finally arrived, was both necessary and insufficient, both correct and delayed past the point at which delay was costless. Federal scheduling of carisoprodol was unambiguously the right action. The prescription monitoring infrastructure is the right infrastructure. The prescriber education that now communicates the meprobamate metabolite risk, the dependence liability, and the combination dangers is the right information. None of this is controversial. The controversy is in the accounting of what the delay cost. 13 years from first scheduling petition to federal action, 5 decades from approval to adequate warning label language, and in the honest acknowledgement of who paid that cost. The people who paid it were not distributed randomly. They were concentrated in populations defined by physical labour and its injuries, by economic marginalisation and its limited options, by healthcare access deficits and their pharmacological substitutes. They were the construction workers and the miners and the warehouse workers and the truck drivers. They were the women with fibromyalgia who hadn't slept in 3 years. They were the veterans whose spines had absorbed the physical arithmetic of service. They were the patients who took their prescriptions exactly as directed and found themselves dependent on a drug that their doctors had never adequately explained, in a withdrawal process that their doctors had never prepared them for, in a healthcare system that had no consistent protocol for helping them through it. The Huxley reference persists quietly in the brand name that the generic eventually absorbed into common usage, Soma, the government happiness pill, the substance that kept the population compliant and comfortable and disinclined to ask difficult questions about the conditions that made the relief necessary. Huxley's Soma was fictional, clean, and without consequence. That was the dystopia of it. the too perfect pharmacological solution to the problem of human discontent. The real Soma was messier, slower, and far more honest in its costs. It didn't eliminate suffering. It deferred it, redistributed it, and in many cases concentrated it in bodies that were already bearing more than their share. The drug is still there, quieter now, more visible in the monitoring systems, hedged with warnings that arrived a generation late and informed by research that took decades to generate sufficient institutional urgency. The back pain it was prescribed to treat, the back pain that has always been there, that will always be there, that no pill has ever reliably cured, is still waiting for the system to find a better answer. The better answer exists in fragments, in physical therapy offices and interdisciplinary pain clinics, and cognitive behavioral therapy programs and occupational medicine practices. It exists in a healthcare system redesigned to value time and comprehensive management over volume and procedural intervention. It exists, in other words, in a future that the American healthcare system has been in the process of building for decades, with a pace and a commitment that remain as yet insufficient to the scale of the problem. Soma is a case study in what happens when a real problem meets an inadequate solution, and the inadequacy takes 50 years to officially acknowledge. The name will change. The structure that produced it has not changed enough. The next Soma is probably already in someone's medicine cabinet, prescribed in good faith, taken as directed, reclassifying the nervous system of a person who was told it was safe. Whether the system that handed it to them has learned enough from this particular history to catch the problem sooner is the only question in this story that doesn't have an answer yet. So here you are, lying in the dark, listening to the story of a little white pill that started with a Czech pharmacologist, watching mice relax in a Birmingham laboratory in 1945 and ended, or rather didn't quite end, in the medicine cabinets and toxicology reports and prescription monitoring databases of a country that spent half a century learning the wrong lessons from its own data. It's a strange kind of history to fall asleep to. Not strange because it's distant or exotic, not pyramids, not medieval castles, not the bottom of a pirate ship. Strange because it's close, because the back pain is real, because the doctor who wrote the prescription was real, because the gap between this is safe and this is causing harm turned out to be not a gap at all, but a slow-moving tide that took decades to reach the people standing in its path. Tonight, as you settle into whatever softness is holding you, your mattress, your pillow, the particular geometry of comfort you've assembled around yourself over years of quiet trial and error, maybe take a moment to appreciate the mundane miracle of lying down without pain. Or if pain is part of your story, as it is for so many people listening to something like this at an hour like this, maybe take a moment to acknowledge that the search for relief is one of the most human things there is. It is not weakness. It has never been weakness. It is the body asking for what it needs in the only language bodies know. The people at the centre of this story were not cautionary tales. They were not warnings written in human form for the benefit of future policy discussions. They were people with bad backs and broken sleep, and real lives organised around the daily management of real pain, who were handed something by someone they trusted and told it was safe. The trust was reasonable, the assurance was wrong, and the distance between those two facts is where most of the suffering in this story lived. What the Soma story asks of us, if it asks anything, is not outrage, though outrage has its place, and not despair, though despair is understandable. What it asks, maybe, is a quiet insistence on paying attention, on asking what something actually does before deciding what to call it, on building systems that see the whole patient instead of the 15-minute complaint, on treating the people who hurt as people who hurt, rather than problems to be efficiently processed and sent back into the world with something to tide them over. The back pain will always be there, so will the search for something to ease it. The question is whether the next answer will be better than the last one, and whether the people who need it will be told the truth about what they're being given. For now, though, the story is done. The pill mills are quieter. The monitoring programs are running. The databases are watching. And somewhere out there, a legacy patient is managing their taper 1 week at a time, and a pharmacist is checking a query before dispensing, and a researcher is writing a paper that will reach a policy discussion in 3 years, and a prescription label in 10, and the long, imperfect, never quite fast enough work of getting it right continues. Let that be enough for tonight. Dim the light a little further. Let the fan do its work. Let your body remember that right now, in this particular moment, you are not required to solve anything. Sleep well.